Committee will be taken up this morning, and then we have a hearing. So I'd like to start the meeting. Senator Blackwell, if you please bring up Senate Bill 2024.
Thank you, Mr. Chairman. In front of us is Bill 2024. It's an insurance bill for travel insurance. Travel insurance does not always easily fit into standard interpretations of current insurance laws designed for major lines of authority, and the changes in this particular bill are based from the industry, based on model language, and to get us in compliance with NAIC compliance. We already have an existing law in place. These are just a few enhancements, though, in the bill. Section 1, we talk about the title. Section 2, the scope and purpose of the bill. And Section 3, there's a number of definitions. And again, these are terms used by the NAIC and NCOIL Travel Insurance Model Act. Section 4 talks about licensing and registration. It basically codifies the NAIC Uniform Licensing Standard, which was adopted in 2010. And by the way, this model bill is in 14 other states, and there's 16 other states looking at to adopt it. Most of the provisions that are being induced are already captured in our Mississippi Code, so there was only some minor revisions. The travel protection plans in Section 6, it provides for travel insurance can be sold as part of travel protection plan, which can include travel insurance as well as travel assistance services. Section 7 is basically the policy. Section 8 talks about the traveler administrators and who manages it. And that's basically an explanation of the bill. I'll be happy to yield for questions. And this bill is also endorsed by our insurance commissioner, Cheney.
Senator Blackwell made a good point. This is model legislation from NAIC, and many of us have attended NCOIL meetings. This is a model bill from NCOIL, trying to get consistency throughout the country on travel insurance. Senator Blackwell, you have a motion?
Title is sufficient, do pass.
Motion is title sufficient, do pass. All in favor, please say aye. Aye. Any opposed? That bill will be reported. Senate Bill 2326. Senator Boyd.
This is another bill that is a model act. You can see on the handout that I provided you, this is a bill that has been fully vetted by NCOIL as well, which is, for those of you who don't know, is both a consumer group and an insurance industry group that comes together to look at model policies. So this is the Insurance E-Commerce Act. You will see that this act, with e-delivery, it is in 38 out of 51 states, and with the e-posting, it's in 25 of 51 states. What it does is it gives consumers a choice by opting in to receive communications from their provider about electronic delivery, but rather than the U.S. mail. The communication includes notices of our policies or documents. Many of us receive this type of information in different banking, annuity policies, and different things like this already. Prior to giving consent and opting in, the consumer is provided a clear statement of what computer hardware and software is required to look at the statements, the type of notices and documents to which this consent applies. They also have the right to withdraw their consent, and they are informed on how to withdraw that consent. They also are still given that paper form is an option that carries you through lines 54 through 104. The second opportunity that's given to consumers is the ability to access the policy forms online. And this is something many consumers want these days, to be able to get these online. E-posting may be exercised by the insurance company in order to allow the review of policy forms for particular coverage, such as a homeowner's policy. You're able to search through these documents a lot easier, oftentimes when they're online. It does not contain any personally identifiable information. In order to provide this consumer choice opportunity, the legislature is being asked to give authorization in a general law. That's kind of just a basic overview of this. It's got a numerous amount of consumer protections in there, and is very balanced, good law. So I'll entertain questions at this time. If there's no questions, I would move title sufficient do pass.
Motion is title sufficient to pass. All in favor, please say aye. Aye. Are there any opposed? That bill will be reported. Thank you, Senator Boyd. Senator McClellan, Senate Bill 2335, please. These next two come to us from the Insurance Commissioner's Office. That was recommended.
Thank you, Mr. Chairman. Senate Bill 2335 is an act to amend Section 45-11-7, it's Mississippi Code of 1972. What it does is remove the limitation on the number of emergency medical responder students that the State Fire Academy may train per year. If you'll remember, back in 2020, the legislature amended this statute in the 2020 session. We added that they could train emergency medical responders. And in the last minute, there was an amendment that limited them to 120. The limitation of 120 students was intended to protect the investment of the community colleges who train, and they have their own system for training, EMT Basic and EMT Advanced. EMR is not an accredited course offered by the community college system. So what we're asking for is the 120 limitation to the State Fire Academy provision of training the EMRs, the emergency medical responders. Training should be removed to allow this. And what this does is the amendment would remove that for them. The Fire Academy's limitation would still be 120 students for EMT Basic and EMT Advanced training. And this amendment would not have any impact on the community college's own investment in EMT training, and this would result in no competition within. The community colleges are on board with this, and this is an amendment to save lives, basically. And I'll take any questions. If no questions, I move title sufficient do pass.
Okay, the motion is title sufficient to pass. Senate Bill 2335. All in favor, please say aye. Aye. Are there any opposed? That bill will be reported. Senator McClellan, Senate Bill 2357.
Okay, thank you, Mr. Chairman. Senate Bill 2357. This is an act to allow counties to pay reasonable hospital and medical expenses for paid or volunteer fire department members suffering injury or illness incurred in the line of duty. It allows for volunteer fire counties to provide accident, death, and disability policy to be paid for volunteer fire department members also. It allows counties to purchase insurance coverage for the medical costs and expenses incurred in the line of duty for volunteer fire department members for counties and municipalities. What happened was the statute back, which was written in 1950, this will amend Section 21-25-9. The state auditor saw that counties could not pay for volunteer fire on the work comp. So what this does, it will allow counties to be within the law to be able to allow these volunteers who put their lives on the line to protect residents and property out in the county, and to allow them to have coverage on work comp, as well as if a county so decides, they can pay minimal expenses out of the general fund for those injuries. This is another life-saving bill. It's also a way to ensure that we keep fire ratings down, because if we lose volunteer firemen in these unprotected areas, insurance rates could double and triple. That's basically what this bill does. If there are any questions, I'll take them. If not, title sufficient do pass.
Senator Kirby?
I just want to make sure it says allow. It's not mandated.
It's
right?
not a mandated, this is not a unfunded mandate. The counties may do this, it's not shall do this.
Thank
There's a motion before us, title sufficient to pass, Senate Bill 2357. All in favor, please say aye. Any opposed? That bill will be reported. Okay, we next have a hearing. I want to welcome House Member Kevin Ford. Representative Ford is working on this bill in the House as well, so he wanted to sit in with us today on the hearing. I'm going to turn the hearing over to Steve Simmons. This Senate Bill 2449 deals with prior authorization requirements by health insurers and physicians. And we have several people that are going to speak to us, and we have exceeded my expectations on getting those bills done quickly, so we have plenty of time. We have to leave at about 3 minutes to 10 to be on the Senate floor. So, Steve, thank you for the people you've lined up for us this morning.
Thank you. Members of the committee, thank you for letting us talk. I thought it important to have a couple of people that have been intricately involved in the only state that this has passed, in Texas. Mara Osmond, she's from Washington, D.C. She's my contact with America's Health Insurance Plans. She's watching a lot of different states that are trying to take a look at this legislation as well as Jamie Dudensing. She's from Texas. Her and her team were intricately involved in fighting this bill in Texas, which again, the only state that it's passed in. But she just she understands a lot of the intricacies of what happened there, and then after they pass this bill, what the implementation of the rules and regs are going to look like. Mara's going to go first, and then Jamie will follow her up. Thank you again for letting me talk.
Thank you. Yes, thank you.
Unfortunately, we couldn't be there with you today in person, so thank you for the opportunity to be there with you virtually. We'd like to spend our time at AHIP here speaking to a few things briefly. And I'll just start out by saying that, as you know, AHIP is the National Trade Association that represents health insurance providers that work to guide greater health. I'd briefly like to talk about these two topics. One, what prior authorization is. Two, their 360-degree view allows them to ensure that medications and treatments that are prescribed are safe and effective for the individual patient. Fire off is also a cost-saving device prevention tool. Removing fire off, which would be a huge effect of this bill, would have very big cost consequences. A Journal of the American Medical Association study found that waste in our health system is about $800 million. And the Institute of Medicine found that billions of dollars are wasted on excessive testing and treatment annually. And there's a trove of data to support this role for fire off. What have we been doing to address physicians' concerns? AFN and our member plans have already been working to improve the prior auth process. We've heard provider concerns about their administrative burden, and we've been working on private market solutions to alleviate the physician's administrative burden without lessening or jeopardizing patient safety. You can find a lot of information about our efforts on our public rights website, and I'd just like to briefly highlight them here. In 2018, we collaborated with the American Medical Association, American Hospital Association, American Pharmacists Association, and lots of other physician groups to come up with a strategy to look at how to improve the prior auth process. In 2019, we surveyed our plans to find out what all the improving things are doing to try to streamline prior auth. We also launched a Fast Path initiative, which is all about electronic prior authorization, where we worked with 2 tech companies and providers and found that PA decisions were received 3 times faster when a physician uses an electronic tool. And so the median time for a turnaround for a decision was less than 19 hours. In some cases, it was 6 hours. This month, they have just published a new white paper focused on new data from a prominent Johns Hopkins physician, surgeon. He found that about 10% of physicians are providing care that is not in line with evidence-based standards. So this demonstrates the need for a more precise prior authorization tool, which is what we're all looking toward. Another key innovative tool that health plans have been using is gold carding programs, which is the subject reportedly of this bill. The gold carding programs that are initiated in the private market are intended to make care coordination more efficient. These programs relax prior authorization for providers who perform at a very high level. These are providers who consistently deliver high-quality care and adhere to evidence-based guidelines. Gold carding is not a blanket exemption for an indefinite period, and it's not appropriate for all treatments and services. It's not free pass, in other words. These programs are targeted to specific services and performance by providers is regularly reviewed. So basically, this is for your A++ providers to get the gold card for specific period and for specific services. The Texas gold carding bill that passed last year distorts the gold carding concept, and this is the language that we incorporated into the Mississippi legislation. It gives less than stellar providers an indefinite free pass for all services, and it removes all the checks for fraud, waste, and abuse and safety checks. It's basically like a blind check of guaranteed payment, so you get paid even if the care was inappropriate or if it was not covered by the patient's plan. The legislation that's under consideration here, as I said, is based on the Texas law, and we urge you not to advance it. While it passed in Texas, it was an anomaly. There were very state-specific dynamics there, and it is not passed in any other state. The implementation has been difficult and cumbersome, and it has not been implemented yet. There are no rules, and it's been delayed because there are so many issues and unintended consequences with the law. We opposed it there in Texas because of the patient safety and cost concerns. Just in closing, and before I pass it to Jamie Benson, health insurance providers use prior auth and care coordination to promote safe, timely, evidence-based, and efficient care. We ask that you put this bill aside while we continue our collaborative efforts to find private market solutions to improve the prior authorization process. Thank you, Chairman and members of the committee.
Thank you so much. Jamie, are you prepared to speak now?
Yes. Can you guys hear me okay?
Yes.
All right. As Steve mentioned, my name is Jamie Dudesing, and I'm the CEO of the Texas Association of Health Plans. Also, thank you for the opportunity to address you today and share some of the lessons learned about eliminating prior authorizations in Texas, and why you should think twice before you make the same mistakes Texas did by adopting similar legislation in Mississippi. Patients deserve the most effective, safest, and most affordable care. That's what prior authorization created gold carding as a part of a value-based contracting to improve quality and affordability. Voluntary gold carding allows health plans to reward the A++ doctors that meet higher standards for safe, appropriate, and affordable care. In return for this upfront flexibility, these gold standard doctors still agree, though, to be accountable on the back end for cost and quality. That's the big difference. Unlike what is negotiated in the private market, the Texas gold carding mandate ends all accountability throughout the entire process, putting patients in danger and creating huge costs for employers. There are three key problems with the Texas gold carding mandate that I would like for you guys to consider. First, the implementation is a mess. The actual implementation of House Bill 3459 in Texas, with an effective date of this past January 1st, has been delayed because the process to actually develop rules from this legislation is so cumbersome. The Texas Department of Insurance is still not issuing guidance because it is wading through a number of implementation issues. This is because the Texas gold carding mandate was never fully vetted and there was no negotiation on the legislation. Even when rules are finally adopted, most plans in Texas are still not going to be able to implement it because of how complicated and administratively burdensome it will be. Most plans have indicated they will just have to turn off all PAs, ending all accountability and safety checks in the system. Every day, we're learning more and more about the unintended consequences of this law. Even if you support reducing administrative burden for providers, please don't rush into passing an untested version of this very expensive, unfunded mandate on employers. It makes sense to pump the brakes and let Texas work out the implementation problems before passing legislation that could land Mississippi in the same logistical nightmare that Texas now faces. The second thing I would like for you to consider is that the Texas gold carding mandate is a huge expense on employers. Without checks and balances or accountability in the system, providers are given a blank check for services, which not only is expensive, but hurts employers and ultimately the families they cover. 65% of physicians themselves report that overtreatment is common, and at least 15 to 30% of medical care is unsafe or unnecessary. Of those same doctors surveyed, 71% believe that physicians are more likely to perform unnecessary procedures when they profit from them. Under the Texas law, employers would now have to cover and pay for 100% of these unnecessary and unsafe procedures. In Texas, eliminating this accountability is estimated to increase premiums for small businesses and individuals more than $1 billion a year alone in the fully insured market. One of our largest plans in Texas estimated that it will cost employers $500 million a year when they have to end prior authorizations across the board. And to give you a more specific example, let's use back surgeries. This legislation would mandate that employers would have to pay for inappropriate and unsafe back surgeries at least 10% of the time. Medicare has found a 7-fold increase in inappropriate back surgeries in this country as a result of profit-driven motives. And they now have recently added prior authorizations to protect taxpayers and to protect patients. One plan in Texas found that about 10% of the back surgeries that were requested in Texas are inappropriate and unsafe, which means they do not meet physicians' clinical standards. The Texas law results in employers now having to pay 100% of these inappropriate and unsafe back surgeries. That one example alone costs $150 million a year for employers. Now the Texas business community is waking up to the problems created by the Texas bill, but it's too late. In Mississippi, you still have the opportunity to pause and see the negative effects before it creates a hidden tax
Jamie, thank you so much for your time this morning. Do we have time for one, we have time for one question if anybody would like to ask, please? Senator Blackwell?
Thank you, Mr. Chairman. I'm just wondering, when did the Texas bill go into effect, and how long has it been, I guess, in effect? Because you talk about some estimated cost, and I'd be more interested in actual cost.
How difficult it's been for rules to be placed out. It was the effective date of the actual legislation was September 1st. The effective date when the gold carding process was supposed to start was January 1st. We are still waiting for those rules. But those estimates are based on actual claims data. For example, the back surgery example is that they denied 10% of back surgery claims because they did not meet clinical standards. And under a gold carding billing with a 90% threshold, that means you would have to pay for those 10% of surgeries that were inappropriate and unsafe. And those claims in Texas equaled $150 million for that piece. So we don't know what the full impact will be, but we do know what the claims are right now for inappropriate services that we will now have to pay for, and employers will be mandated to pay for.
Well, it's not the employers paying for it as much as the insurance companies, but so you're saying that where the cost to the employers is going to be is increase in premiums?
Capped on what we can have for admin and profit. That means that all medical services flow through there the way utilization price works. So if there is a huge utilization increase and inappropriate services, premiums will actually increase by that amount.
Thank you, ma'am.
Thank you so much. Jamie, we thank you for your time this morning. We have a couple of committee members I know are going to have to leave for an important vote in the Education Committee. But I'd like now to ask for Sidney Allen to please come forward. Sidney Allen represents the Mississippi Independent Physician Practice Association, and he has a couple of speakers that he'd like to introduce.
Is that better? I'm sorry. So, yeah, I represent MIPA, as we call it, and we were formed in last fall and represent 33 different independent physician practices across the state, about 300 doctors. And we ran a survey of our members to ask them just to gather intel and see what was impacting their practices, what was impacting their patients, y'all's constituents. And the overwhelming reply was prior authorization issues, and it's just a burden on their practices, and it really impacts patient care, which is really what we're here to talk about today. We started doing some research and found the Texas Gold Card law that the insurance companies have already talked about this morning, and sort of modeled the bill that we're talking about today, 2449, off of that bill. You know, we're not trying to take away the prior authorization procedure from insurance companies and their right to do that. It's not even contemplated in this law. What we are doing is saying any doctor that has, or a doctor or any medical practitioner that currently is required to get a prior authorization, if they have proven over a 6-month period of time that they are above a 90% approval rate for a specific procedure, that for the next 6-month period, they don't have to go through the prior authorization process for that procedure. I mean, you know, we're hearing these horror stories. It's like we're on two different planets here, but that's all this is doing. So, I mean, we're not trying to eliminate the insurance company's right to do that. And I think we drafted this in a way that they still can provide whatever procedure they use for prior authorization. We're not impacting that. It's just that they can allow a physician or a dentist or any practitioner that is required to get a prior authorization. They review it for a 6-month period starting January of next year, so we're not shoving this down their throats overnight. And the first gold card as we're calling it, the quote-unquote gold card, would not even be issued, at the earliest it could be issued would be next July 1st because of the 6-month review period that they'd have to go through. And from there on, there's a 6-month, we're kind of living in 6-month blocks of time, if you will. The insurance companies have the right to continue to do their utilization review like they do now, and I'm sure they will continue to do that to make sure that let's just use a doctor. We're going to hear from Dr. Jeff Allman next with Mississippi Sports Medicine, who's an orthopedic surgeon. So Dr. Allman, you know, if he's not living up to that 90% threshold during that utilization review, then they can rescind his gold card. So we're not taking anything away from the insurance companies under this bill. Like I said, I think it's very important to know, and you've even heard the insurance companies talk about it, that this is, the bill will not even truly go into effect until January 1st of next year, and the first gold card would not be issued for at least 6 months after that because they're going through this 6-month review period. So I know we're on a very tight schedule. I'm not an expert. Now, I want y'all to hear from some physicians and others. Y'all have seen the agenda. Like I said, Dr. Jeff Allman, I believe, is joining us. I believe he's on Zoom. I can't see if that's... Yeah, there we go. All right, so Dr. Jeff Allman is with Mississippi Sports Medicine, orthopedic surgeon. He's going to tell you about some issues they have with prior authorizations and how this could be a relief to them. And then you see Dr. Catherine Panel, who's the chairman of the State Medical Association, and Sabra Sullivan, who's a dermatologist, will speak. And then the last presenter is the Texas Medical Association, who can kind of give you the counterbalance to what we've just heard from the Texas Health Plan Association. So at this point, I'd like to turn it over to Dr. Jeff Allman.
Thank you, Cindy, and thank you, Senators, for your time this morning. I'm here with my nurse, Hamburger. She runs the show here, and so she can, give additional information if I don't know. So I will say this about prioritization. It's become so onerous for all of us, and it's to the point now where
Dr. Allman, Senator John Horn has a question.
Thank you, Mr. Chairman. Dr. Allman, you mentioned that it sometimes can take up to 2 weeks to get a prior authorization approved. 4 weeks.
For a lot of patients. 2 weeks on some things, 4 weeks on others. Surgeries usually 4, so we go that way. Surgeries are usually 4 weeks, and then I guess for other diagnostic studies like MRIs, CAT scans, things like that, they take up to 2 weeks.
On average, how many prior authorizations do you have to get on a monthly basis?
So a month, let's see here, so I average 21 surgeries a week, so I'm gonna say a little over 100, probably, easily over 100.
Per month?
Yes, sir.
Okay, thank you. And on average, how many disapprovals do you get for prior authorizations per month?
I'd say at least 20%.
20%?
Yes, sir.
Okay. And what, the gold card that's being talked about in Texas, are you a supporter of that? Okay. Thank you very much. Thank you, Mr. Chairman.
Senator Blackwell?
Thank you, Mr. Chairman. Doctor, when you and your staff are doing these reviews, are they peer-to-peer, or are you guys dealing with somebody administratively that maybe just has is going a logarithm in front of them that they're going through and saying, you've hit this, okay, you've hit this, okay, oop, denied?
Yes, sir, that's the case. So it's usually like that, it's a nurse, a nurse is dealing with an administrative person with that particular insurance company. And then when it gets denied, it's about 20% of the time, and I have to get on and spend 30 minutes to an hour discussing the case with an orthopedic surgeon who has not been in practice for over 10 years usually, and may not, be up to date on all the latest and best techniques and treatment regimens.
All right. And then in those cases where you do receive a PA, provide the care, what number of your cases then come back retroactively denied?
Well, the ones that they get prior authorization, they normally don't get denied. The issue that I have though with the potential problem that I see here is that if we do get the gold card and we don't have to undergo prior authorization, can they then not pay later to say that the patient didn't need the surgery or didn't need that test? I don't know what kind of protections we have in that part as well, because that's where that can happen as well. I know that one of my partners had a patient that had a particular insurance and broke their arm and went to the emergency room, showed up, the patient was referred to the emergency room to my partner, and he operated on this young man and fixed his arm and got denied treatment because that particular insurance company required that the patient be referred from a primary care provider. And
Dr. Allman, we sure thank you for your time this morning. Sydney, would you please introduce our next guest? Thank you.
Yeah, thank you. Next, Dr. Catherine Panel from Oxford, who's the chairman of the State Medical Association, is going to present.
Thank you, Mr. Chairman. My name is Catherine Panel. I'm chairman to the board of the Mississippi State Medical Association and a practicing psychiatrist. Thank you for having me today to speak about the burden prior authorizations place on physicians and patients. When I completed residency, I thought I was going to be able to go out and practice medicine in the way that my education and training prepared me for. I was going to provide the best psychiatric care to my patients. That means evaluating, diagnosing, and providing the best, most appropriate treatment. I never dreamt that I would have to justify that treatment decision to insurance companies who aren't even involved in the patient's care. Justify why my patient deserves the best treatment to someone in writing or over the phone who has never even seen or spoken to my patient. Prior authorizations have become extremely burdensome to physicians and patients. Physician burnout is at an all-time high, with PA burning being cited as a top contributor. Health insurers are increasingly requiring physicians to obtain PAs before being able to provide medications and medical services. In addition to consuming clinical hours that could be better off spent seating and taking care of patients, these requirements are interfering with the physician's decision-making, restricting care to patients, and most importantly, delaying patient care. It is impacting specialties where a delay in care could lead to a poor outcome or even death. As a result, this past August, physicians unanimously passed and adopted a resolution in the MSMA House of Delegates, which was designed to streamline the prior authorization process and is mirrored after the Texas Gold Card legislation that was approved this past year. Physicians have reached out to MSMA to help with the burden that PAs are placing on them. We surveyed Mississippi physicians to see exactly what that burden would look like, and you also have a handout in your packet with these slides. The survey showed that, I think the slides are actually backwards, but 97% of physicians reported that access to care has been delayed because of the prior authorization process. Next. One of the more startling results of the survey was that 49% of physicians reported a serious adverse effect due to prior authorizations affecting delivery of appropriate care. This was death, hospitalizations, or disability. Next. %90 of physicians reported that the PA process leads to patients abandoning their recommended treatment plan completely and going to a different treatment plan just to speed up the process of treating their patients. Next. 93% of Mississippi physicians reported that because of prior authorizations, there has been a negative impact on patient outcomes. Next. And of over 600 physicians surveyed, 243 physicians reported completing 11 or more prior authorizations per week. Next. ,86% of physicians report that their practice spent up to 20 hours a week each week processing PAs. This was about 2.5 work days to complete these prior authorizations. Next. And therefore, a third of the physicians have had to hire staff just to exclusively work on prior authorizations. Next. So in a perfect world, prior authorizations would not even exist, but with this Gold Card legislation, this is a big positive move to help ease the burden on physicians and patients from prior authorizations. Thank you.
Senator Blackman.
Thank you, Mr. Chairman. Dr. Pannell, you mentioned that a lot of physicians were saying burnout, and a lot of them cited because of prior authorizations. Did they quit the practice of medicine?
Well, and that's a really great question, especially during COVID right now, because the insurance companies were supposed to actually ease the prior authorization process because physicians were getting so burnt out. But yes, there's a good amount of physicians who have left clinical care due to physician burnout, and this was one of the top reasons.
And do you have any kind of percentage?
I don't have a percentage.
And you stated, well, you've given us this handout, and you said that you surveyed 633 physicians out of a total of how many in the state?
I don't know how many are in the state. I know that with MSMA, there's about 3,000 plus physicians.
Okay, thank you so much. Thank you, Mr. Chair.
Any other questions? Thank you, Dr. Panel. You've been busy today, haven't you? I think I heard you on the radio on the way in. I know, I got caught in the same wreck you did. All right, Sydney, thank you.
Yes, sir. Next up is Dr. Saber Sullivan, who's also with state, or a representative of the State Medical Association. She's a practicing dermatologist.
I'll try to be brief. I'm Dr. Saber Sullivan. I'm a native-born Mississippi. I have an MD, PhD, and I'm board certified in dermatology. I went to medical school at Dallas, Texas, Southwestern, did my internal medicine training there, and then went to Stanford and completed my residency. I came back to Mississippi as founding chief of dermatology at the University of Mississippi Medical Center in about 1995. I left that position in 2003 because I had to have a pancreas kidney transplant and I was a single mother. So I'm also a mother, a wife. My relationships with my community and my family, I do all those things. I'm not just somebody trying to make a bunch of money off of patients. And listening to all this testimony today, it brought up real sadness in my heart. I never expected when I went to school and I trained and I came home and have been very active in patients' rights and advocacy that I would be accused of trying to make money off my patients. I'm also a small business person. I may not be able to practice much longer. I went from a staff of 8, where I'm the only physician, and I had nurses working part-time, and the staff doing the front, so I could see a capacity of patients. And I'm a dermatologist who takes Medicare, and I take insurance, and I also have specialty clinics where I take everything for children in Mississippi, and I have both insured and uninsured patients and Medicaid patients, and I'm not limitless. But in my office with COVID, that's the other thing, that's the elephant in the room here. We're just all ignoring COVID like it's a real, nothing's happening. It's the Wild West in medicine. People are taking advantage of a number of things. You can't legislate morality. You just can't. You can't do it in medicine. You can't do it in any specialty. But we can use our heads and have some common sense and not cut off access. So I've gone to, from my employees, who I can't get employees anymore in my private practice that has been full for years, and we're continuously trying to take on new patients, especially children that have severe birth defects. And I also go to the operating room, as with what I do with working with vascular defects. I also do skin cancer surgery and try to take care of seriously ill dermatology patients, of which I'm all sure. There's no one in this room that hasn't wanted to see a dermatologist, right? At some point, it's all easy, get my Botox, go. That's not what it's all about. But I am currently spending, I have an aide, I have one RN, and thank God she isn't leaving me for travel nursing, going from my whole staff. And I have one person up front. Someone volunteered to me yesterday that they would sit at my front and answer the phone, and an office manager. My office manager spends usually about 10 to 15 hours a week trying to get pre-certs. So what's pre-cert? Well, someone has insurance, it should be fine, you can get on the phone and call. No, you can't. You have to find out what the insurance is, you have to find out which particular plan the patient has, what the coverage is, and it's switching day to day. That can be by an employer where the patient has no choice. There are all many different ways, and everybody has a different plan. So you have to get clearance whether or not you can provide care. Then you have an emergency, and you have to decide, like in some of my instances, if I'm going to just go ahead and do it. And a lot of times I can do it and eat the cost, and I've done that for 20 years. It's getting to the point that I can't meet my overhead no matter how much free care I give away. And to have a child, say an 8-year-old that has a defect that I've been treating, I get a pre-cert from the previous insurance company that I can see her and treat her when I need to look at her at 8-week intervals. And I may not need to do a treatment, but I have that pre-cert there, so if she's traveled from 5 hours away, they don't have to come back, and I don't have to spend another 2 hours of my time or my office manager's time on the phone. Then that should be good. You know, I should be able to re-up that pre-cert as I follow the patient along. I can't. And a lot of this is designed to keep us from getting patients care. It's not to do about quality or access. I don't want 10% failure, but who goes into a surgery saying it's going to be 100% correct? You know, all the time. How can you say that people are just trying to make money off of it? You can't hurt the providers, the PAs, the NPs, the physicians that are trying to provide care for their patients when we're in the middle of COVID and we can't get anybody in. There's a business aspect to that. I can give everything away, but the day that I can't pay my staff, my rent, then I have to shut down, and I may be at that point very, very soon. My patients are waiting for me in my office today, very graciously, because I got asked to come do this. So I'm going on, but it just gets worse and worse and worse. It's not any better at the institutional level. We have big health disparities in Mississippi, and we are making them worse by trying to accuse everybody as if they're doing something wrong. If I can ever get through, I haven't ever had anything denied, but it may take me, 2 hours out of the day when I'm behind on 30 patients and I don't have an appointment or trying to get them worked in. Texas, what's happened there? Are we talking to people that are practicing day to day? I don't think so. We're talking a lot to executives or people that have made a living out of going and try to promote this and saying what we can't do. Every law has unintended consequences, but we're in crisis here in Mississippi. We're in a bad crisis with physicians, providers, and being able to deliver care. I can deliver a lot more care. I don't need to make any more money, but I need to be able to treat my patients and then make sure I'm not going to get sued because I didn't provide care because an insurance company told me I can't do that. Now, I've been denied with a child that was bleeding from his eye. Now, I treat a lot of adults, and I see the same thing there. Is this really necessary? As a dermatologist, there are over 3,000 diseases. Many of them you haven't heard. But when you get one of them and you know about it and you know you can treat it, and then you have to go through treatment or get authorization, people get sick. They get sicker. They can get worse. They give up care. Patient called me the other day, I can't bring or can't come in, I don't have gas money to get to your office. Can I reschedule? Yeah. Well, their prior authorization runs out, and I have to go through that whole process to get to see them again. So I'm just going on and on and on. But I am tired. I haven't quit yet. Like I say, I go to work every day. I'm a pancreas kidney transplant. I am trying to do everything I can for my patients. I've been the State Medical Dermatology Association president. We've lost so many to COVID. Do people retire? Yeah. Everybody at my age in their 50s and 60s. I would say there were about 8 dermatologists that retired this year simply because of this or the past year or two. We need to do something to help this burden. I talked to my endocrinologist friend yesterday. She says it's the equivalent of a full-time employee to go through pre-certs. And it's restricting care. It's restricting access. We have limited appointments. We have health inequities in Mississippi. And we're preventing care. I just recently had a 3-level neck fusion. I went in the hospital. I did that. I came back when I wasn't supposed to. See my nice scar. Love my neurosurgeon. But I just cannot tell you what it's like. And then as a patient, being a transplant patient, I have 5 stents in my heart. But I go to work every day. But I need a cholesterol medicine, or I needed one that came out that was new, and I can't take any of the others. So it took, I had to go through 4 medicines I had failed before in the past because I hadn't been on any of them because I couldn't take them, in the last 5 years, and had to fail all of those before I could get the medication I needed. So sometimes this just gets out of hand, and I'm going to stop now. But this is about patient care, patient access in practicing and delivering health care to our constituents here in Mississippi. So I'll take any questions, and I'd like to introduce next Dr. Zeke Silva from Texas.
We have 1 minute. We're actually got to be in session in 2 minutes. And Dr. Silva, what would you like to say to close, please? I'm sorry, we cut into your time. Thank you so much for your time this morning, Dr. Silva.
Thank you.
Senator Younger moves we rise and report. All in favor?